Hi, I'm Dr. Josef Witt-Doerring. I'm joined today by Dr. Ethan Short, a psychiatrist, a couple of years behind me in coming out of training and all of that. And he had reached out a couple months ago, and I guess after seeing my channel, and I was really pleasantly surprised to see that we were on the same page about quite a few things. And I was so excited so that I said, hey, we should jump on and do a podcast and talk about the state of psychiatric training at the moment as someone who's kind of gone through. And Ethan kindly agreed. So that's what we're going to be talking about today. So, Ethan, thank you so much for coming on and speaking with me.
Disclaimer: this podcast is for informational purposes only. The information provided in this podcast and related materials are meant only to educate. This information is not intended as a substitute for professional medical advice. While I am a medical doctor and many of my guests have extensive medical training and experience, nothing stated in this podcast nor materials related to this podcast, including recommended websites, texts, graphics, images, or any other materials, should be treated as a substitute for professional, medical, or psychological advice, diagnosis, or treatment. All listeners should consult with a medical professional, licensed mental health provider, or other healthcare provider if seeking medical advice, diagnosis, or treatment. Or, put more simply,
if you need help like this guy, call your own doctor. Somebody get this guy some help!
Absolutely. It was a big relief to be able to find your podcast and some other podcasts to just kind of know that I'm not alone in my opinions. I mean, I try to scour the work of a lot of better known psychiatrists that I have a lot of respect for. So I knew I wasn't completely alone, but it's nice to find somebody who's also relatively new out of your training. I think you told me you're about, is it 5-6 years out, something like that?
Mm-hmm. Yep.
And talking about the same ideas. And then, we talked for 15 or 20 minutes on the phone that one night. And yeah, we were just kind of fanboying back and forth on different issues that we kind of aligned on. And I think we have a very similar overall view of psychiatry and recognize a lot of major problems within our field, but also probably both recognize that the anti-psychiatry movement goes a little bit too far and under recognizes some of the more biologic problems that we see in psychiatry. So yeah, pleasure to be on here. And then of course I'll be doing a reciprocal here and featuring you on my podcast as well, Renegade Psych, which was started because I had to have some sort of outlet for kind of some of the problems that I saw in the field, and that maybe I'm not, taken as seriously as a second year out attending psychiatrist with some of my peers or some of the folks that I'm working with as a young psychiatrist.
Great. So I think I want to just jump right in and kind of throw a massive question at you, and we'll see where we go from there. So Ethan, tell me, what do you think about the state of psychiatry in the US today, the way it's practiced?
Well, I would say the word abysmal comes to mind. I think we are just, and I don't think it's just medicine. I don't think it's just psychiatry. I think we're living in a society that is being sold and oversold everything. I think that has filtered its way into the field of medicine and the field of psychiatry in particular, because we're kind of shooting at targets that are a little bit hidden. We don't have great biologic explanations for our illnesses. And that leads to kind of a situation that's ripe for corruption. And, I think you and I are both aware of so much corrupted research out there, kind of empty promises. It seems like the same story plays out over and over, where you have a drug that gets approved. It's touted as 100% safe, 100% effective. And 20 years later, when data comes out that it's not as safe or it's not as effective as we originally believed, all of a sudden the pharmaceutical company that had a exclusivity on that patent for their brand, when that runs out 20, 25 years later, they don't really care at that point. But I think it's really sad that we keep seeing the same type of situation play out over and over. And I know you've talked about the issue with big tobacco and, trying to create this illusion of doubt that nicotine or cigarettes are causative factor in lung cancer. So this is something that's been going on for 50, 60, 70, probably, more years than that.
So you're touching on the fact that you're getting the sense that medical research is maybe not as forthright and honest as it ought to be, and that's kind of leading the practice astray. What I want to ask you about is, how does this affect the person in the clinic from what you see, in training, or what you've seen for your colleagues and all of that? How does this crisis in the confidence of the evidence basis behind our medicines affect the patients?
Well, I think you come out of medical school and, I think we're all a little bit green to some of this stuff. We believe that we're there to help people, that the field is there to help people. And I think we can be a little bit naive to the financial interest that are kind of existing in the background. Well, maybe it used to be the background, now in the foreground of healthcare. I think it's tough when you start to see others questioning data and you look at some of the information that they're presenting, and there's a lot of factual nature to it. And, we go through medical school, as you take all kinds of tests, most of which are multiple choice, and you get in the habit of picking the right answer, right? It's either A, B, C, D, or E, or a host of other, answers. And I think that kind of tricks us, or it creates this illusion that there is a right answer so often. What I've found is that there are maybe multiple right answers or multiple shades of right and wrong answers. And it's tough to have a lot of what you learned in medical school, a lot of what you have answered on these multiple choice tests, and have that kind of foundation shook. Hard to become more comfortable with a lot of the uncertainty that goes into what we do. I mean, I think a prime example of that is a drug like lithium. I talk about lithium a lot on my podcast because I think it's probably got the best evidence of any psychiatric medication. Yet, going through medical school and into residency, I was really taught to fear it. I wasn't taught a whole lot of nuance about dosing. It took a while for me to understand that it's the only real medicine we have outside of, clozapine, a atypical antipsychotic that is very difficult to use, that reduces the risk of suicidality. I remember that in residency and training, that being such a point of contention for me, that I would ask so many of my attending psychiatrists about, why am I pegged to prescribe a medicine like an SSRI that's first line for depression, but it's got a black box warning in adolescents and young adults for being a causative factor in suicide. Like, I mean, I'm not the most, intellectual person in terms of understanding, really in-depth pharmacology, but I think that one of my strengths is that I do have some kind of wisdom and overarching concepts. And one of those is that, these SSRI drugs, they don't know when you turn 18. They don't have some mechanism that knows when you become an adult. So that, that was kind of one of the, I think, major issues that really started to make me question a lot of other things in the field.
Well, let's actually start there, really. I want to, when did you start, I guess, waking up to some of the problems in psychiatry? Was this in med school? Was this during residency? Tell me the personal story that you went through to kind of make these discoveries.
Well, the personal story I think goes way back. I think I understand a lot more about myself in the eyes of my field, and that kind of my own nature. I think I come from a family that has a pretty significant deal of what I think is the better classification, calling it manic depressive illness, which I think it's so important to conceptualize that way because you didn't ever have to have episodes of mania to be on that spectrum, but it guides a lot of treatment. And so anyway, I'm kind of giving that background because I think that I've always had this sense of depressive realism and kind of a skeptical nature about everything. And it's not that I don't believe, everything that I'm told. It's that I just want to remain a little bit open-minded. I guess I think of things internally in terms of like percentages. And if I'm 95% sure of something, that's pretty good. But if I'm only 95% sure that somebody's not going to attempt suicide, that's not good enough. So there's kind of nuance there, but I've always been a little bit skeptical of things. I've always asked a lot of questions, been very inquisitive, and in residency, I think that is met in a couple of different ways. One is kind of sit down and shut up. Or I was thinking about this morning. I don't know if you follow the NBA at all, but LeBron James has his Showtime series called Shut Up and Dribble. And I think early in my residency, I started to feel a little bit of that same sentiment. Like, shut up and do your work, shut up and prescribe these meds, do it based on guidelines. But at the same time, I had a couple of very, very crucial influences, really positive influences that helped me to establish a good bedside manner, and most importantly in our field was pushed to critically think about everything that I was doing. My first year I was working in the psych ER and University of Louisville, where I went to medical school and did my psychiatric residency, is at the time was one of 10 or 12 places in the country that had a dedicated psychiatric ER. And I'm sitting there, in my first couple of months of residency, I really don't know what I'm doing. I've got an upper level on one side and I've got an attending psychiatrist on the other. And a patient comes in, we evaluate the patient, they leave, and we're amongst ourselves talking about, what do you want to do? And the attending says, Dr. Short, what do you want to do? And I said, oh, I want to start this medicine. I wish I could remember what it was. He said, well, why do you want to do that? And of course, I'm sitting there shaking in my boots. And, I say, because it's FDA approved for that condition. And he steps back and he says, Short, that's one of the worst reasons that I've ever heard somebody say as why they want to start a medication. And so that kind of funny story, that was kind of an impetus for, him telling me you can't just trust the FDA approval. Got me kind of thinking and being a little bit more skeptical about the field. I don't know if that really answered your question or not. It was a little bit roundabout.
No,
but
it's good, yeah. And I guess what do you think he was pulling for, really? With this question.
Well, he's a huge critic of. He was on one of my episodes about lithium. Actually, his name's Rif Al Malik. He was just a huge critic of our training system, and the fact that we are taught to memorize these things, like I alluded to earlier with the testing, but not taught to necessarily critically think. And years later, with where I'm at now, wonder if that is built into the system intentionally. You have this entire population of really high achievers, really competitive people, and then you throw them in together and they're competing to be these high achievers, to get the best grades on the tests, all whilst accumulating a significant amount of debt. And I think it kind of creates this culture of feigned certainty. I remember being a medical student on rounds, and you get asked a question and you really want to be correct. You want to prove your worth. In hindsight, I think what a lot of attendings were looking for was more of that critical thinking skill. But I think the whole system kind of filters us into this. You need to be certain about what you're doing, and you need to display that certainty to your patients. And to be completely honest, those are some of the worst providers in any field that I see, that aren't able to keep an open mind about even things that they were very certain about throughout their training, being presented new information and be able to change their opinion on it.
Yeah. You mentioned El Malik, and I imagine it's quite unusual for someone to have an attending who may be more critical, about psychiatric medication, because, I am familiar with his articles on, I think it's tardive dysphoria is a concept that he kind of, brought forward, which I think is a really interesting one. And so I'm just curious, tell me about Rif El Malik. What is he like? Because I know he's not quite as public as the other people who are out there. And I do know he says critical things, at least in the literature. But I've always been curious on knowing a little bit more about him as a physician and kind of, how he practices and all that. Tell us about Rif.
So, he's somebody that I think was somewhat split amongst the residents, because he did push you. I mean, he asked a lot of questions, and I think it was easy to kind of shut down around him. But I think I recognized early on that he wasn't trying to be critical of the trainee sitting in front of him. He's trying to be critical of the system. He's trying to push us to, really think about what we're doing and appreciate the fact that we're manipulating people's chemistry, people's biology in prescribing the drugs that we prescribe. And sometimes, like with his work with tardive dysphoria, he's putting it out there that we may be causing more harm in some classes of patients than others. But on a whole nother note, he does work with industry, and he's worked with industry for a long time. And he talks about it in a little bit different light, that this has been going on forever, and done the right way, it can be really useful to have a system where people do work with industry. Of course, I would encourage you to listen to our back and forth on it. It's really pretty interesting, because he does acknowledge that these are, major problems. But I think he also comes from a different time where there wasn't as much ability, in the 70s, 80s, early 90s to manipulate the research. There was a little bit more separation, and you weren't seeing, 10 of 11 or 11 of the last 12 FDA commissioners going within a couple of years and working for big pharma. So I think he recognizes it, but he doesn't see it as big of an issue as I do. We're supposed to go to dinner next month, and I'm excited to hear our discussions on it. Probably my favorite thing about the man is that he's willing to discuss anything. He wants to discuss anything.
Tell him that we spoke, and ask him if he'll come on my show to talk about tardive dysphoria.
There's no doubt in my mind he will. The other thing about him is he's one of the most driven people that I've ever met. I mean, of course, I don't agree with every opinion, every clinical decision that he makes. And I'm sure he doesn't agree with mine either. But when you see the way that he interacts with his patients, how much he cares for each individual, and he's the only attending that I worked with that, he had a bipolar clinic every Thursday afternoon that starts at 1. Anybody else with a specialty clinic, outpatient, they're out of there by 5, maybe 5:30. He's regularly there until 7 or 7:30.
Hmm.
And yeah, some residents like to, bitch and moan about that, but at the same time, he's there because he gives time to each patient. When they have questions, he'll hang around, he'll answer them, he'll meet them where they're at. So I always had a hell of a lot of respect for, that critical thinking aspect. And then also just the way that he obviously cares about his patients and, has this intellectual curiosity about things that I think is just wonderful characteristics for a psychiatrist or a physician in general. Not to
Yeah.
mention, he also trained under Kay Jameson, who did a lot of the really crucial work in illuminating the other kind of positive side of bipolarity or bipolar illness, or that manic depressive illness. And I think wrote several books about her own experience with bipolar, but also about how many poet laureates were qualified as being on that bipolar spectrum.
Hmm. Yeah. It's sort of interesting how these chains go through, because maybe you would have gotten there anyway, but I always think it's interesting that you came across Riff, and who I know, who is very critically minded, at least from what I've read of him, and the impact that had on you. And well, let me ask about your colleagues, because something I was interested in during our initial conversation was that you didn't feel so alone, which was my experience in residency. I felt like I really was the only one who was having a problem with how psychiatry was being practiced. I got the impression that you were in a cohort of psychiatrists who did have an open mind and who were questioning things. Can you tell me more about that?
Yes, I will, but I'm really curious to hear first about kind of your experience with it. What kind of was the light bulb or the light bulbs for you in terms of recognizing that there are major problems with the field and with what we're doing.
Sure. Yeah. So let me see. What's my story? I would say that I've been interested in mental health probably because I'm interested in personal development, and I've been interested in that for a long time since I was growing up. I don't know why, but I mean, naturally, it occurred to me that if I'm having problems and things like that, I'd look to books. Maybe it's because my family read a lot, and I I even I even remember finding like a Tony Robbins book like in my bookshelf growing up. So I'm like, self help. This is kind of interesting. And my dad read a lot of philosophy, which really is also a kind of self help mindset type of a lot of the literature is in that way. And so from a pretty young age, I was interested in that. I had like most psychiatrists, my own kind of problems and my own insecurities and my own things that I struggled with, and I would turn to books. And when I was in medical school, I remember thinking, well, what specialty should I choose? Maybe I'll do psychiatry. Something about that would dovetail nicely with my interest in personal development, psychology, the world, existentialism, kind of all of those things. How to live a nice life, a healthy life, and such psychologically. And I mean, to my horror, I entered residency, and there was none of that really. I remember thinking, and this is not like something that I had read or an expectation that was told to me by anyone. It was more of my intuition was like, yeah, sure, we're going to use these meds sometimes, judiciously and cautiously for some people, but mostly we would be kind of really getting to the root of why people were having problems, understanding them, pointing them in the right direction in terms of social services, psychologists, things like that. Anyway, no surprise to anyone listening right now or anyone that's interacted with American healthcare or much healthcare in the Western world. That's not what it is. It's in many ways it's a conveyor belt, and because I think because it's expedient, we end up relying on medications, and also because I think there's a strong desire to kind of fit in with the group and to sort of, work efficiently. You end up going. Let me try and connect the dots here a little bit better. When you're training, you've got to be quick, and when you're quick with seeing your patients and things like that, you end up trusting people, and trust what your attendings do, and you kind of fall back on them, and in the way you practice. And sometimes it's like, oh, yeah, 5 out of 9 symptoms, prescribe this med, and go for it. And that's just kind of how we efficiently move through things. We go, okay, well, I trust this doctor. He does it this way, and so I will do it as well. And that's what allows me to kind of get through things. But slowly over time, because I had that little itch inside where I was just, what, this really doesn't seem right. I started looking for answers, and eventually, the more I looked, the more I found out that actually, much of the way that we practice has been, doesn't really make a lot of sense. In fact, we are constantly being kind of pushed a narrative that, the drugs are safer than they are, less risky than they are. They can be prescribed very easily. And that's really just not what the evidence shows. And I know, my backstory. I was at the FDA and in industry for a while studying these drugs. So I know what the evidence basis is for using them. I know how long they study them and, what the maintenance studies look like. And essentially it was just bullshit. So the more I sort of looked at it, the more I realized, we ended up in a place where we had, a whole workforce of doctors who kind of, want to fit in with one another. They'd been educated by essentially marketing, masquerading as science, and I just had a real problem with that. I mean, another story is like I took Xanax for about 5 months as well myself. Just PRN, one every now and then. But the way that story ends is, eventually one becomes 2 a week, then 3 a week, then 4 a week, then 5, and then you take it every single day. It fucked me up. And
it works great for the 6 or 8 weeks that they study it, though, right?
Yeah, it works great for the 6 to 8 weeks they study it. But then I started having obsessive thoughts where my mind would just carousel, the most shameful, embarrassing things that had ever happened in my life, before my eyes. And I can talk about caffeine and nicotine use as well, because that also plays a role in my story. But I want to kind of keep it to the point. But, I do have some personal experience with the medications. But honestly, where everything came from for me was just like, I know how to, I can smell like a fraud. I can smell a lie, and it gets under my skin, and it gets itchy, and I'll pick at it until it comes out. And I don't know why that was me, but it just was. There was something wrong about what was going on.
Yeah, I think you and I share that it really does get under my skin. And sometimes I wish it didn't. Sometimes I know you've talked kind of semi-recently to Adam Urato, and I just talked to him and have his series coming out relatively soon. I wish I could be more like him on a personal, his jovial kind of upbeat nature, even though he's fighting a very similar fight to the one that we're fighting. But I was curious. I wanted to ask you, because of my own experience with, shedding the certainty and opening my eyes to all the things that I used to be certain about, and now I have questions about, some of the most basic things that I learned. That was pretty hard for me personally. It was really disheartening to see the field as a whole and kind of wonder, is there anything I can do? And I found myself getting very frustrated, to go back to your question earlier about working with others and trying to educate them in so many different ways. And maybe it's because, I'm a young physician, young psychiatrist, and talking to even, mid-level practitioners that have been doing it for 20 years. Maybe they're past that window of embracing the uncertainty and kind of questioning their own belief systems. But that aspect of kind of my personal journey has been pretty tough to navigate and has had certainly some ups and downs in terms of, yeah, just trying to educate people and then feeling a lot of the time like people just don't care. You know, they just want to live in their little bubble, go about their day, do their job, make their money, spend time with their
Mhm.
family, all, you know, things that are all very important. But I guess for me, at the end of the day, at the end of my life, even if I'm not able to really move the needle, uh, it's something that's so important to me to try to do. But damn, it is so damn frustrating sometimes.
Yeah, it is. Yeah, yeah. And so
How do
I,
you take that personally? Like, how do you manage that frustration?
no, I think I'm just going to shoot from the hip and just give you some general thoughts that I've had about people. What motivates the way people do things. I think some people are really motivated by wanting to understand things, and it's like they want to know it inside and out. And I'm not trying to say this to be kind of dismissive or even rude, but that I don't actually think that's the motivation. That's a primary motivation for a lot of people, although people do expect that from healthcare providers. What I do see is I think a big motivation for a lot of people can sometimes be to fit in, can be to do a good job, and they may not think about how everything's going on. They may be thinking more about efficiency and speed and practicing in alignment with their peers and with their supervisors and being accepted in the group and things like that. I think there can be a very strong social pressure that leads to a group think, and that makes sense, from a biological perspective. We want to stay in the herd in many respects, because once you leave the herd, you know, people say, oh, well, they're criticizing, now they're criticizing us. You're going to stick out. You're going to be practicing outside of things. And I really don't think people like that. And so, to be more comfortable with practicing in a different way and to have these beliefs, I mean, there's risks associated with that, which a lot of people just like, no, thank you. I've got a nice life. I have a nice income. I'm respected by my colleagues. I've got the hang of things at work. I'm probably just going to hang on to that because I don't really care enough to get, that's not a priority for me. And that's just the way the cookie crumbles. Like that's just the way some people are. So I anyway, so the way I dealt with it, Ethan, was essentially I had to leave. I had to start a practice. I had to hang up my shingle as someone that's just doing deprescribing, and I think it'll be interesting to maybe to talk a little bit later on about this. But I probably I don't think I would be prescribing drugs like lithium any more than short term, even things like Clozaril. And I am aware of the suicide benefit, but I do, in many ways, my journey is one where I think the deeper I've gone in this hole, I think the more I have become someone where I'm just like, you know what, I'm not going to start any meds unless it's for this really short period of time. We'll do it for like a couple of months. We'll get you through it. And unless there's some exceptional circumstance, I don't think I ever put someone on long-term psychiatric meds. That's kind of where I ended up landing. And so that sort of influenced my practice where I'm like, hey, if you want to come and work with me, you have to drink my Kool-Aid. You have to be someone that's like, I'm looking for something else. I'm looking to come off meds, or at least I'm looking to minimize my medication burden to the extent possible. And now I only work with people who share that same belief, because yeah, it's frustrating to work in a system where people are working against your mission. And so I constantly just moved into that direction, and now I'm sort of fighting to have a successful practice in that area. And it's a fight, but it's been really rewarding.
Yeah, I think one thing that I kind of mentioned or left out, didn't mention, is that during my residency, I was also exposed to some of Stephen Hayes' work,
Yeah.
University of Nevada, the ACT therapy kind of godfather, if you will. But I was much more interested in the underlying theory about ACT, relational frame theory, and kind of how the different parts of our brain understand language. And some of his talks really, set a light bulb off for me, understanding what my internal experience was and using that, so much more heavily moving forward. I remember, I don't know about your experience, but we had a weekly therapy clinic and we were just kind of thrown in, with the wolves. Hey, go do therapy. And it's like, well, how? What do I do? Without a whole lot of specific direction. And I kind of really struggled and stumbled through those half days a week for really probably a solid 18 months in my residency. And then I came across RFT and ACT, and I remember listening to Stephen Hayes talk, and I was sitting there, my skeptical nature for 15 minutes was, what the hell is this guy talking about? He's not really making any sense, and he's jumping all over the place. And then I had what he calls the click of understanding, and I think that really has shaded my understanding of how people's minds work in general. The fact that we've got this voice that we don't have control over when it inserts itself into our stream of consciousness. And that voice also presents language in this very black and white way, very all or nothing way, almost like, we talk about the symptoms of borderline personality. And almost as if the mind, it tries to create this order in our lives to make us, I guess, feel better, really. And, if it's either this all or nothing thing, it's, I always think about it like the mind understands the word happy, the mind understands the word sad, but it takes that consciousness, that kind of frontal lobe function, and for us humans to understand the huge gray area between happy and sad. In ACT, it's called fusion. If the conscious me that I hear and now, the part of me that is sitting here talking to you and vice versa, if that part of me is fused with the information coming from my mind, kind of that supercomputer, that information processor in a world that we live in of massive amounts of information on a, daily basis, I see that play out our society, in politics, right wing, left wing. Are you on for this idea or are you off of this idea? When I really feel like we all need to have much more of an appreciation for so much of that middle ground. And I think, honestly, it kind of plays out with lithium in general. I use a lot of lithium, but most of the time I use it at very low doses. A lot of supplement doses and a lot of the lowest prescription dose, because that really has, people don't realize we're already taking in lithium through our environment. It's a trace element, and kind of wonder if we've maybe restricted the intake of lithium by trying to purify all of our food and water. But it's that same idea, and lithium is a great example because I've worked with people who really don't understand, and they see the word lithium, and I think it sends alarm bells off in their brain that this is this dangerous drug. You're going to hurt the patient. And it's, again, I think there's a lot of incentive by industry with that drug to create that kind of culture of fear, because I prescribe my patients 90 days of low dose lithium. Without insurance, it's about $8. There's a lot of incentive for us to not prescribe it. And again, it's got data going back for, a long time. But anyway, I just use that example to illuminate, I guess, some of the ways that I think I see society thinking and not appreciating this, all the things that are stored in our minds and when relevant are kind of projected to our consciousness. I just don't think there's enough of an appreciation for that and how that aspect plays into what we're talking about. that desire for order and certainty, because it makes us feel better. If I know where I stand, I at least have somewhere to stand, versus if I'm just kind of floating around in the milieu of uncertainty and, not fully understanding things. It's difficult. It takes kind of dedicated mental work to become okay with that.
Yeah. Yeah, I like what you said, and I think it's I've had similar. Well, I guess my overarching position is the more I've gone through this, I started to realize actually that as great as the brain is, it is really a very economic organ, and it does have its weaknesses, right? So the brain is trying to develop rules about the world and people and such, that it's learned over time. And then it kind of wants to execute those rules without questioning them because you've got to be efficient. I mean, you can't be using all your computational power to rethink things every single time. You'd be less functional. And one of the interesting things about being in the business of helping other people navigate life, which is what we do, is that we get to see the software, the ideas that have been downloaded into them from their life experiences, how it helps them and how it harms them. Probably the one people are really familiar with is trauma. How you grow up in a family of childhood sexual abuse, things like that, and it absolutely destroys your ability to have relationships in some cases, because if you learn the rule that even those people who are meant to care for you the most can all of a sudden turn around and do horrendous things to you, you're always going to have this feeling of distrust that will hold you back.
And that rule can be extrapolated too, right? It doesn't just have to be the primary abuser.
Exactly.
The mind can take that and it can become any authority figure. And so you can find yourself reacting to things later in life that they don't really make total sense to you, and you may not draw that connection between a trauma with one individual and then a later kind of re-experiencing of that trauma or reacting like you're in a traumatic situation, even though consciously you may realize this is a totally different situation. But the way that you feel, kind of that mind, that emotional center, that involitional thought center, you're not as in tune with that. You don't understand that it all kind of comes.
That's it. That's that gut feeling. Something feels wrong. And that's where it's coming from, right? The prior trauma, and maybe if someone's listening to this in your audience who may not be familiar with trauma, maybe another more accessible example of this, which some people may be more familiar with, is how your family deals with money. So I'm more miserly with money. It's something that I've had to learn, develop ideas about it. I think about my dad. He's Austrian, grew up in the wake of the Second World War, in Austria, inside that loss, right? And what it was like for him and his mother to survive, and how penny pinching and how careful they had to be with food. And my mom comes from a fairly, I would say, working class background as well. And so the way I look at money is completely different from my wife, who grew up pretty well to do. And, I have a lot of these ideas of, we shouldn't spend this, we shouldn't spend on that, when obviously it makes sense in some situations where it's like, why would you save money here when, if you would just spend this money, you would have more time, it would be better, there's more enjoyment. And so, I mean, there can also be other things that you learn and you don't question, and they kind of just sit with you, and they make up your programming. And I think that's happening with all things in life, that we are learning these patterns for efficiency, and we don't question them. And a lot of times we don't actually see how they fail us because they feel so right to us.
Yeah, it's interesting. You and I do have some shared experiences. I grew up in a family that did have money, but my father, who's a physician, a urologist, came from very little. His dad died when he was 6 years old, and so it was left to his mom to carry multiple jobs and raise the four children. And he was, kind of the only male in the family, was kind of thrust into this role at an early age. So I remember growing up, I didn't understand why I couldn't go on certain field trips, knowing that we had the money. But in hindsight, I understand that, it's being taught very, very valuable lessons about money, that it isn't just something that everybody has. And I look at that a lot differently now than I did back then.
Mm-hmm.
Stephen Hayes has and I'm sure this isn't, I don't know if this is his work or not, but he talks about an experiment where they have two groups of grown adults, and they go into separate but identical rooms with a game. And group one gets a very basic rule about the game, and group two gets nothing. And so in that, first room with the game, group one is able to figure it out. It still takes time, but they're able to figure it out a lot faster than group two. Group two eventually, through trial and error, figures out this game, unspecified game. But then, of course, every cool experiment like this, there's a part two that is more illuminating than part one. They go into a second room, and there's a different game, and it's unique from the first game, and they tell the participants this. But when they go into that second room, group two, who got no rules in advance, they're able to, through trial and error, figure out this second game a lot faster, with the idea being that group one was still stuck with that rule ingrained in their minds for that first game. And as much as they didn't want to, they're trying to apply the rules of the first game to the second game. And I think this is something that we can never fully understand all of the rules that have been paved in our minds. Our job is just to continue to try. And our job professionally is, I think the biggest job we have is to try to help our patients on that journey of understanding themselves and understanding the influences that go into their decisions outside of their conscious awareness.
It's so interesting because I think that it was kind of an unexpected gift in many ways of doing ending up in psychiatry, because I mean, you don't. I feel like I've learned so much by working with people and just being exposed to all the different ways people think about things and how different I am. Oh my God, from other people's, and how I tick, and I think probably the best therapists and all of this stuff. I mean, it's really hard to learn this stuff. I mean, I think the only way you learn it is by talking to a whole lot of people who are really different from yourself, and seeing how they respond to things, what their gut feelings are, how it serves them in different situations. And it's a shame that we don't really talk about that as psychiatrists anymore. We're so stuck on the meds. But I mean, that really, I think, is probably one of the best things about being in this career, is learning that part of it.
Yeah, absolutely. I got one thing to add that I kind of slipped my mind talking about. I guess what got me questioning things happened really in medical school, and in learning about the state of addiction in the United States, and the state of addiction in, I mean, Kentucky and the areas surrounding Appalachia are just absolutely rampant. And these are things that I saw growing up here in Louisville. But in going to medical school and seeing the numbers of overdoses and the numbers of HIV infections, hepatitis C, endocarditis or heart infection, all the different complications of it, and kind of, the curtain being lifted on Purdue Pharma and what they did with Oxycontin, I think that was really the impetus for me to really start to question everything. Because that's something that has been, very revelatory, and we've revealed a lot of information about kind of what they were doing in the background, trying to say that an opiate, which opium has been around for centuries and centuries, was somehow not addictive, and being able to sell that to doctors and the American public. And the passion part for me is I graduated high school in 2007. I went to a good high school. We had it was all boys high school. We had close to maybe 350 graduating in my class. There's a dozen people from my class that are dead now from overdoses. Or if not dead, they've had their lives derailed by opiate addiction, by different drug addictions. So that really hits me, and like I take a personal offense to that, because there's people that I grew up with that aren't here anymore, and it's not just Purdue Pharma. I mean, this is something that, the more that I've investigated with my podcast and doing the research for each series, and getting different guests with credentials that are way more impressive than mine, that have decades of experience working in the field. That was a huge impetus for me doing, going into psychiatry and wanting to work in addiction. But then just seeing how the whole field of addiction, what we're doing isn't working. Yet there doesn't seem to be a whole lot of interest in seeking out different ways of doing it. So anyway, that's something I just wanted to add, because it really is a major influence and a personal motivation of mine, that drives me.
Yeah.
So I did have a question for you.
Sure.
So obviously you're probably not working with a lot of these types of conditions in outpatient, but kind of where do you draw the line on where maybe the anti-psychiatry movement goes too far? And I'll give you a little bit of
Sure.
my kind of personal thoughts or background on it. I hear people talking about things from the anti-psychiatry movement. I think Peter Breggin is one that I think goes a little too far, and doesn't appreciate some of the nuance. I'm hoping to have I don't know if you're familiar with Joe Pierre at UCSF. I think he's got a good kind of middle ground. Yeah, I'm trying to get him to come on. I'm interested to hear what he has to say. I've listened to him on the Carlet Psychiatry Report a little bit, and looked at some of his posts on social media. And I think he does a good job of kind of riding a line closer to the middle between what you could call the complete pro psychiatry movement that follows every guideline and prescribes everything that they're supposed to prescribe, versus the anti-psychiatry movement. And I was curious to hear, where do you fall on conditions that I would say are very biologic? Prime example being something like catatonia.
Sure. Yeah. Let me give you my download on it. Is I definitely believe there's genetic loading for certain conditions, and that genetic loading interacts with the environment, and then it causes the symptoms, whether that's legit mania, melancholic depression, schizophrenia, psychosis, and catatonia, and things like that. So the place where I get worried is I actually don't believe that medications help people long term. And that's something that's taken me a while to get to. And so why do I believe that? Well, it's because I think there's problems with tolerance. I think, due to homeostasis, that eventually over time our bodies will push against those forces and will adapt to them. And so that's one thing I'm worried about, is that, most of the drug effect is probably going to be at the start, but then long term, it's probably not going to be helpful. And then I worry about risks, long-term risks of the medications, whether it's weight gain, metabolic side effects, liver problems, and things like that. So I think that's like another piece of it. And so I guess where I come to is that, the long-term use of medications for me is always going to be first and foremost PRN, because, if someone has a bipolar episode or a mania or something like that, I guess where I'm at is, um, I don't know if I really believe that the meds improve their disease trajectory. For me, it's more of a, okay, you're manic at the moment. Do you want to burn through this mania without meds, or do you want to take something to get you through it? At which time I would bring them off. Um, and then I suppose in some exceptional circumstances, if someone kept on having problems, then maybe I would consider long-term use, but it would be, I probably wouldn't feel very good about that. And that's the same with psychosis. I would say that, okay, so what, someone has schizophrenia, psychotic illness, there's cognitive problems, and also psychosis. Well, I see a lot of chronicity with the antipsychotics. I think they work in the short term. They can be blunting, but they also have hugely negative effects on other aspects. Um, I think they make people depressed. I think they uh, zap any kind of motivation and such. And sure, for some people they may be okay, but in general, I actually think that they're quite negative. And this is based on my own experience, so it may not apply to you. This is what I've seen, and so my advice to them would be, use the meds as needed if you really need to. I mean, always the ideal outcome for me would be learn to live with the voices, learn to live with the paranoia to the extent you can, and rely on the meds as little as possible. I'm also not naive. I know that, right now I work in a place where people are coming to me for that, but in most community settings, we've got a lot of psychotic illness, and their lives are pretty terrible. They're using drugs, they don't have support, their lives are incredibly stressful, and they live in these states of psychosis. And maybe for them, taking the drug long term is kind of helps, but still in the back of my mind, I'm just like, it's probably going to make this condition worse in the long run, because they're going to become dependent on it. They're going to need higher doses, and then eventually they'll still be psychotic, but just massively on the drug. And so, ideally, we have the social supports to help these people in a way where they don't need to rely on the meds so heavily. Catatonia, that's another one of those things. I think if someone has catatonia, or a short course of Ativan or even ECT sometimes is reasonable. But so I think I'm totally on board with catatonia. I don't even think we really ought to be using any long-term medications for catatonia. I also think it would reduce chronicity there. Yeah.
Josef, you bring up a point that has always kind of gnawed away in the back of my mind, and it is the homeostatic mechanisms that we naturally have, that innately exist, and we don't talk about that nearly enough. Tardive dysphoria is one example of, changing your chemistry over time with long-term use of a medication. But I've always questioned even things, that are supposedly extremely effective with, what we call now treatment-resistant depression, things like old drugs, MAOIs. I really do question what is the role of using these long-term, and that other lever that you're, innately have, that is trying to restore you to whatever balance, your brain and your body think you're supposed to have. That is not talked about long or nearly enough. And similar to the fact that our drugs are not studied intensively in a long-term enough fashion, probably because there's nobody that's willing to fund it more than anything. But, I would say that you and I probably aren't too far apart on, again, It's not like this all or nothing thing. You're not that 100%. You're not that 0%. I'd say we're definitely in line with the fact that we recognize that everything in our field is overdiagnosed. Everything is overprescribed. We rely too much on medication, rely too much on this biologic component of mental illness. But I think for me, there's probably a few more conditions that would respond to a little bit more prolonged treatment. Now, I agree with you. The antipsychotics, Dr. Al-Malik actually gave me some really good bits of education on this. You know, he said, if you're a manic patient, you're hospitalized, and, you know, I tell you, I can give you this drug lithium that will, you know, break your mania in a couple of weeks, or I can give you an antipsychotic that'll break it in a few days. You know, which would you prefer? And so he also educated me on the fact that the state of illness that people are in with manic depressive illness, bipolar disorder, where their mood is at should dictate, ideally, how you use the medication. You use, for example, higher doses of lithium when somebody's ramping up into a manic state. And then because their brain chemistry changes when they return to a more normal state, you drop that back down. And you typically can get away with a little bit lower doses with the depressive pole of bipolar. But you're absolutely right on that point of what are we doing with this chronic manipulation? If I'm giving you, for example, that MAOI that is increasing the amount of dopamine, norepinephrine, serotonin available to your brain, well, there's got to be a feedback loop that says, hey, this is too much. Or when you come off of that, you're almost certainly going to be in a very depleted state. Not to mention the other, you know, risks of that. And we could have a parallel with serotonergic drugs like the SSRIs. So, yeah, I mean, I hear you. I think some things like ECT, I think that there are good indications, and it's a treatment that I've seen people broken out of catatonia that were not responsive to Ativan or other benzos. That was one of the most incredible, you know, aspects of my training, was seeing multiple, you know, depressed with catatonia or bipolar catatonia patients, a couple of ECT treatments, and somebody who wasn't eating, drinking, moving, you know, is at risk for severe muscle breakdown because, you know, essentially they're in a state of contraction all throughout their body. I think there are roles for these things, but again, maybe.
Let me jump in there because I want to. I you know, I don't want to come across as not getting it, because and I don't want people to feel bad if they're on the meds, because the reality is that sometimes they're the lesser evil, you know. And here's some things I'm thinking about. Think about autism, you know, aggressive autism, which is a really difficult condition to treat. It's all well and good for someone like me to say, oh, you know, the meds are going to make him worse long term and all of this, and, you know, you really ought to stay away. But what else are you going to do? I mean, unless you have substantial resources and you can afford to have someone there, you know, watch and redirect your child, which honestly 90% of people don't, then the meds are what you're going to do. And that ends up being the practical thing, the realistic thing. Same with dementia, with behavioral problems as well. You know, if a little bit of Seroquel is going to keep your dad at home with you, with the people that he loves, a little bit longer at the end of his life, you can't afford to have someone watch him and redirect him the whole time. That makes sense as well. You know, if that's going to be, you know, how you're going to reason that. But as long as you know what you're getting into and you're making these decisions in a thoughtful way, I think there definitely are places to use it. I just don't think it should, for many cases, it should ever be what someone, you know, what the ideal situation. As for ECT, ECT, I've seen people snap out of it as well, and people feel really strongly about ECT, especially in the drug harmed groups and such. I've seen ECT work, but the one problem that I have with ECT is usually it comes after multiple drug mistakes. Like, you've had someone in an SSRI, they've got tardive dysphoria, you kind of cycle them through a whole bunch of different drugs. It makes them worse. They're fully, they're depressed, they feel terrible, they're on high dose antipsychotics and antidepressants. And then at that point, it's like, oh, treatment resistant depression, give them the ECT, where it's like, well, you broke their brain with the drugs first. And how about helping this person come off the drugs first, watching them, see if they're going to recover before you just stack another intervention on top of it? That's the problem that I have with ECT. I think it's just, the last tool in the toolbox of just throwing ineffective meds at people. That's how I kind of see it. But if someone just comes in, severe depressive episode, not on meds, although I've never really seen them before, and they get ECT and then kind of snaps them out of it, then I think that's great. Same with catatonia. I think ECT for catatonia really does work. But I think the way we use it as this treatment of last resort, in many times after we've already harmed people with the drugs. Again, I'm shooting from the hip here and not trying to mince words, just kind of sharing things.
Somebody get this guy some help.
Thanks for listening. For more social media content, check us out on all social media platforms at Renegade Psych. If you have any comments, questions, or challenges to the information we presented here, or if you'd like to be a guest of the show, feel free to email us, renegadepsych@gmail.com. Follow the link in the show notes to our website for source material, transcripts, and additional links for my guests. And if you feel passionate about our message and what we're trying to do, and you'd like to donate, you can also follow the link in the show notes to our website. Thank you.